Good morning, everyone. Good morning, Archana. Good morning,
Good morning, ma'am.
Good morning, Manasi, Shruti. So, Dr. Joyita is here. I request Dr. Joyita to start today's class and introduce both the speakers and moderator because they are from TMH team and she knows the best about both of them. And it's an important topic as we discussed last in continuation of that topic. I think it's a very, very important topic and I hope that all the PGs will be benefited. Go ahead, Dr. Joyita.
Thank you. Good morning, Sushma ma'am. Good morning, everybody. It is our pleasure to do this topic today for IAPC Online from Tata Memorial Hospital. So to do the presentation is Dr. Shruthi Kamble, who is our second-year junior resident in the Department of Palliative Medicine. Her areas of interest are management of palliative care emergencies and pediatric palliative care. Our moderator for today is Dr. Manasi Patil. She is our Homi Bhabha National Institute Pediatric Palliative Medicine Academic Fellow. She is by training a pediatrician and then has done her MSc in Public Health. Her areas of interest are providing novel ways and for holistic care to children with advanced cancer. And she is also very keen on facilitating the establishment of networks for children in need of palliative care within the pediatricians community through training and advocacy. And both Shruti and Mansi are very vibrant members of the team, and we have a common coffee club that we are part of. Shruti likes to draw and Mansi likes to work out. So with that introduction, it's over to Dr. Shruti to start our presentation. Thank you, Shruti.
Thank you, ma'am. Good morning, everyone. I hope my screen is sharing. Everyone can view the screen. So yeah, beginning with the definition. One second. Okay. So beginning with the definition for children's palliative care, which is given by Together for Short Lives. It is the palliative care for babies, children, young people with life-limiting conditions, which is an active and total approach to care from the point of diagnosis or recognition throughout the child's life and death. It embraces the physical, emotional, social, and spiritual elements and focuses on enhancement of quality of life for the child and young person and support for the family. It also includes the management of distressing symptoms, provision of short breaks in care through death and bereavement. Now, what is largely known or practiced in pediatric palliative care revolves around postnatal and young children. So this topic will help us realize why palliative care should be incorporated in the perinatal, especially the antenatal period as well. So coming to a few statistics, based on the Global Atlas of Palliative Care at End of Life, the data is given by the WHPCM. The need for palliative care in children by disease groups is mostly taken by congenital malformations and premature birth and birth trauma, which accounts together for 34%, followed by preceded by HIV diseases, which accounts for 29.6%. According to the population, the low middle income and low income groups also have a lot of need for palliative care. And the African and the Southeast Asian regions are the ones who require a lot of palliative care. Together for Short Lives has also categorized children with palliative care needs into 4 categories. So the first category involves children with life-threatening conditions for which curative treatment is available but may fail. This includes cancer, congenital or acquired heart disease, infections or blood diseases, and organ failures. Category 2 involves long periods of intensive treatment which aims to prolong life, but premature death is inevitable. This includes children with HIV or AIDS on antiretroviral therapy, cystic fibrosis, muscular dystrophy, chronic or severe respiratory failure, or immunodeficiencies. Category 3 involves progressive conditions with no curative options, while treatment is palliative from diagnosis, but the life may extend for years. These involve children with metabolic disorders such as mucopolysaccharidosis, mitochondrial disease, neurodegenerative diseases, Rett syndrome, chromosomal abnormalities, and neuromuscular diseases. Category 4 involves children with severe disability that leads to extreme vulnerability to complications and premature death, where there is an unpredictable course, but the disease is non-progressive. This involves children with severe cerebral palsy, neurological consequences as a result of infection, hypoxic brain injury, or traumatic brain injury. It also includes brain malformations. What we need to understand that all these diseases have begun since the conception, since the implantation in the intrauterine life. So there are a lot of factors which take place, which could be maternal factors or factors due to exposure to certain drugs or increase in the maternal health, age groups. So a pregnancy is termed as a viable pregnancy beyond 6 weeks when there is a heartbeat present. So by 6 weeks, the organ systems, the limb buds, the eyes, ears, and the vertebra begin to form. By around 10 weeks, the fetus has a face like a human profile. And around by 12 weeks, the CNS forms from the neural plate, which develops into grooves and folds upon itself to form the neural tube. And the closure of the neural tube further forms the spinal cord and the brain. Non-closure of this neural tube leads to certain conditions which are known to be non-compatible with life, which is anencephaly. Coming to the trimesters of pregnancy, pregnancy is divided over into 3 trimesters. The first trimester comprises of the first 3 months, the second trimester of the third to sixth month, and the third trimester of the sixth to the ninth month. What we need to understand here is that as the pregnancy evolves and progresses further, the attachment and the bonding, the maternal bond between the mother and the child will increase, and loss of the child at any phase would lead to distress for the family and the mother as well. Now, this palliative care for the neonatal age group has been divided into prenatal and neonatal palliative care. So the prenatal period is divided into the early and late prenatal palliative care, and neonatal is divided into early and late neonatal palliative care. So while doing a lot of research for this topic, I found this article that is the model of palliative care in perinatal setting, which is a systematic review of literature, which had around 1,500 articles, which had mostly a lot of comments, reflections, clinical studies, proposals, and reviews. So the qualitative analysis of the content showed that the concept of palliative care began gradually, and it is not perfectly defined for this subgroup, but there are various interrelated aspects which overlap. So it begins initially with pain relief and having comfort care plans, and also involves the maternal bond, the family-centered care, and the comprehensive psychological, social, and spiritual aspect. And since we're talking more about the neonatal age group, it also includes bereavement start right from the beginning. And with this topic, we'll understand why antenatal period also should be considered, because once the family has been given a diagnosis of a condition which is life-threatening or relatively life-limiting, the bereavement and the counseling regarding the future aspects of life should begin from that period. The British Association of Perinatal Medicine has suggested categories where perinatal palliative care is indicated. It includes antenatal and postnatal diagnosis of a condition which is not compatible with long-term survival, an antenatal or postnatal diagnosis which carries high risk of significant morbidity or death, and it includes babies born at margins of viability where intensive care has been deemed inappropriate. So the Together for Short Lives and the National Institute for Healthcare and Excellence, that is the NICE, has published guidelines and framework to guide professionals in developing and delivering care for neonates with life-limiting or life-threatening conditions. So this begins with sharing of significant news. This is the start of the journey. After recognition of a life-limiting or a life-threatening disease, it can begin in the antenatal period, it can begin during or following the birth of the baby. This is normally triggered by professionals, by parental concern, or by critical event which happens during or after birth. With a lot of advances in technology and antenatal diagnosis, such as genetic testing and radiological investigations, certain conditions can be confirmed with certainty, whereas there is some sort of diagnostic and prognostic uncertainty which will still exist. There could be various reasons for having an abnormal test result during this phase. It could be due to a preterm anomaly, a preterm birth. It could be due to infection, maternal comorbidities, or asphyxia, or IUGR, or any congenital malformations. So every family should receive disclosure of their baby's prognosis in a face-to-face discussion in privacy. They should be treated with respect, honesty, and sensitivity. And all this information should be given to them in a language that they can understand. It is of vital importance that medical jargon should be avoided in this phase. Coming to the next standard, that is planning for going home. There should be a transfer plan which should be ready to, which involves the family and the carers, the hospital, the community services, and the hospice services as well. Now, during the transition into a hospice, there should be availability of a person from the hospice who comes to the hospital and who's present there supporting the family before they are discharged. The family should know who to contact in case of query if they plan to discharge and go home. And resources before leaving the hospital should be available with the parents and with the family. There should be multi-agency assessment of the family's needs in the way that the health, psychosocial, and practical needs should be addressed. There should be a multi-agency care plan so that we can deliver coordinated care and support their individual needs. Here, the most important thing to understand is there is continuing uncertainty. The parents might feel overwhelmed with the many decisions that they have to make. We should have utmost respect for their spiritual, religious, cultural, personal beliefs, and the family here is a team who is caring for the baby, but it should not be forgotten for they themselves also require care. This is an appropriate time to also develop your antenatal advanced care plan. It should also have details of the diagnosis and the options offered regarding the place, the timing, the mode of delivery, and monitoring in labor. It should also involve input from fetal medicine consultant regarding discussions about the pregnancy, details about where the baby should be delivered and whether specialist facilities are required should be noted. There should be a record of the discussions and decisions that have taken place on extent of resuscitation, organ and tissue donation. Details of postnatal care of the baby also should be noted down as to if they wish to have skin-to-skin contact and who can be within the delivery room. This care plan should be reviewed by the families at request if at all they require any change in the aggressiveness of interventions. An end of life plan should also be in place so that it will help the patients and the family members to get the appropriate support that they need. It is important for professionals to also recognize and identify when end of life is occurring, because it could be immediately after birth, within hours or after days, or it could also be after discharge in the hospice. And continuing bereavement support. So bereavement is something that will happen absolutely along the way of this pathway, right from the beginning, the day one setting, right up till the end and beyond the baby's death as well. So this is the perinatal pathway for babies with palliative care needs. It summarizes the previous aspects, like the first standard, which is sharing significant news. The second standard, planning for choice in the location of care. Stage two is the continuing ongoing care, which involves a third and fourth standard, that is a multi-agency assessment of families' needs and care plans. Stage three, that is the end of life and bereavement, which includes the fifth and sixth standard, that is an end of life care plan, continuing bereavement and support and care. So the NICE guidelines for end-of-life care for infants, children, and young people with life-limiting conditions have given the following recommendations. Where possible, the baby receiving palliative care, including end-of-life care, in the place that they choose. Babies with life-limiting conditions should be cared for by the multidisciplinary team who meet regularly to discuss the child's care. There should be parallel planning so that families and professionals are prepared for a change in the child's condition. Involving neonatal medical teams in care planning for a child if there is an antenatal diagnosis of a life-limiting condition, recognizing importance of managed clinical networks in delivering high-quality coordinated children's palliative care. The baby's family should play an active role in the discussions about their care. Just so that we can get a more clear understanding of all the aspects that we need to address, here's a case study of Mrs. G, who is a 27-year-old G2P1A1L0 who is married since 4 years to her first cousin, who by occupation is a domestic help, a resident of suburban Mumbai. She lives with her husband and her in-laws in a 200 square feet house with an attached bathroom and toilet. Her husband does odd jobs to make ends meet. They are Hindu by religion and socially active in their community. They have been taking pilgrim trips in the hopes that someday they will be blessed with a child of their own, given their 4 years of marriage. On their regular ANC visit, the family was told by their obstetrician that the fetus is diagnosed with anencephaly, a condition incompatible with life. So, what do we really understand here? So this patient has been pregnant for the second time now with a viable pregnancy, which she's had and an abortion in the past. And she's been married since 4 years. There's also history of consanguineous marriage. And given their occupations and their financial insufficiencies and their faith in a higher power that will help them relieve of all their and have some miracle baby. So on their regular ANC visit, the obstetrician has told them that they have anencephaly, a condition incompatible with life. So here the main thing that we can understand is consanguinity is a major reason for having chromosomal abnormalities. And also we need to address spiritual beliefs of these patients and also give them hope if this is the coping strategy for them in case of further pregnancies with the same diagnosis. So the WHO recommends at least 4 antenatal visits for diagnosing all these conditions beforehand. So the timing of the first visit or registration should happen as soon as the pregnancy is suspected. Every woman in the reproductive age group should be encouraged to visit her health provider if she believes she is pregnant. Emphasis should be put upon that more than 4 visits could also be required depending on the woman's conditions and their needs. So the first visit should take place within 12 weeks, the second visit between 14 and 26 weeks, the third visit takes place around 28 to 34 weeks, and the fourth visit between 36 weeks and term. Various screening tests are used to diagnose antenatal fetal abnormalities, such as the nuchal translucency test. This is done during the first trimester. The triple test, which includes the alpha-fetoprotein, beta-HCG, and estriol. So the beta-HCG is increased along with decreased levels of AFP and abnormal levels of estriol in trisomy 21 and 18. Elevated levels of alpha-fetoprotein are seen in neural tube defects, such as in pinna bifida and anencephaly. Amniocentesis is done by around 14 to 16 weeks, and chorionic venous sampling is done around by 10 to 12 weeks. So what next? After Mrs. V has been diagnosed with this condition, obstetrician has broken down the news to her. We need a multidisciplinary team who comes into the picture. So this involves the fetal medicine specialist, a neonatologist or a pediatrician, a palliative medicine physician, senior nursing staff, and bereavement support team and social worker. So now the textbook of interdisciplinary pediatric palliative care has the components of a prenatal palliative birth plan and neonatal advance directive. So after all this is done, we need to break the news to the patient. So we have certain tools which can guide us to help in delivering this news. So the most famous and commonly used is the Spikes protocol, which involves setting up the interview. We need to arrange for privacy in these patients for this setting, and we need to involve all the significant family members who need to be told about this condition. This could also involve the parents and also the extended family, such as the grandparents or anybody who's closely related to the family. We need to establish a rapport with the patient and also make sure that there are no interruptions during this sensitive time period. We need to understand what is the family's perception of the disease as of now and what is the level of comprehension. And there could also be some sort of denial at this stage. But what we need to understand is that we cannot confront the patient at this stage. We need to give knowledge and according to the patient's wishes, according to the family's wishes, and we also need to accept the right to not know. And we also need to offer them the questions and offer to answer the questions later at any time when they come. The information should be given to them in smaller chunks given the current emotional state, and it needs to be given in a way that they understand, avoiding medical jargon. There needs to be also space given for emotions. It could also be by just giving them silence, the way they process it. They could be distressed, they could be in denial, they could be in a lot of anger at that point. What physicians need to understand is at this point it's very important to just listen and explore whatever they are thinking. And in the end, that is strategy and summarize. So we need to identify the coping strategies and reinforce the coping strategies. And this is something that needs to go on continuing from the beginning till the end. Another framework is the ABCD framework, which involves advanced preparation, building a therapeutic environment or a relationship, uh, good communication, dealing with the family reactions, and encourage and validate emotions. So after we have summarized the goals for the baby, care of the mother and baby during labor and delivery should be emphasized based on the timing, routine, and location of the baby's delivery. Management of the mother's pain during labor, the extent of monitoring the baby's heartbeat during labor. If parents have a strong desire to meet the baby alive, possible interventions that can be done for fetal distress to prolong life. Postnatally, presence of family members or friends within the delivery room, faiths, tradition, prayers, or rituals which are to be initiated soon after the baby's birth. So coming to the medical termination of pregnancy, after being told about the diagnosis, there could be certain family members or the mothers who would like to terminate pregnancy. So within India, the MTP, the latest Amendment Act in 2021, allows unmarried women with contraceptive failure to also undergo MTP. The gestational age limit has been increased from 20 weeks to 24 weeks. And the requirement for a registered medical practitioner is also reduced to one registered RMP by 20 weeks of gestation and two RMPs for 20 to 24 weeks. And beyond 24 weeks, we need a medical board approval. So the initial care and management of the baby, the extent of desired resuscitation measures and clear DNR or limitation of emergency treatment orders should be noted. Use of warmth to maximize comfort and minimize unwanted symptoms. Use of suctioning and free flow oxygen. Management of pain, dyspnea, seizure, and other symptoms. Uh, Care for the family following delivery. There should be opportunities to maximize families' time together, including the sibling presence, memory making, keepsake activities, ritual, and photographs. There should be plan for communicating baby status to the family and friends and not at the hospital. Ongoing care and management for the baby. Comfort measures including warmth, mouth and lip care, kangaroo skin care. Potential initiation of nutrition, breast and bottle feeding, formula via dropper, tube feedings, use of suctioning and free flow of oxygen, management of pain, dyspnea, seizures, and other symptoms, plan for extent of diagnostic testing, such as no X-rays, ultrasounds, or blood draws, plan for if baby will stay in mother's postpartum room, newborn nursery, or NICU. So now palliative care in the delivery room, there were certain challenges and recommendations offered based on those challenges in this paper. So this involves being open-minded and attuned to the parents' needs when empathetically communicating information, assured continuity of interdisciplinary and interprofessional care for the parents and child, thorough interdisciplinary and interprofessional planning for the child's birth and postnatal care, planning that should serve the best interest of child with consideration of values, wishes, and needs of the parents. Taking into consideration how the health concerns of the mother and possibly other siblings may be impacted by prospective palliative care plan for the ill child. Close coordination among all practitioners on the care team, including medical and nursing procedures, adequate symptom control for the newborn throughout the dying process, the creation of valued memories for the bereaved parents, bereavement support for the family, for the parents and families. Anticipatory bereavement care. So now what we need to understand from the beginning, from the diagnosis, the patient, family is the one who's going to experience loss. Even though the child is present in the womb, maybe in a alive status, they're expecting for death, they're expecting loss. So good anticipatory bereavement care plays an important role in lessening the intensity of post-death bereavement, as well as providing valuable opportunities for bonding and memory making. Elderly parents should not be asked to sit in the waiting room alongside women with healthy pregnancies on arrival and in the antenatal clinic. Mothers should be given an option as to how they want to continue their pregnancy. When parents have chosen to continue their pregnancy, they should meet with a member of the bereavement specialist team for anticipatory care, inclusive of placing emphasis on the baby alive in utero, discussing memory making of the pregnancy and following delivery, sibling involvement in accordance with parents' wishes and consent. counseling and support in managing uncertainties of loss and life expectancy, preparation of birth inclusive of documented parental wishes, birth references as discussed with the family and multidisciplinary team. Discharge plan for infants who survive the postpartum period. This involves an anticipatory plan for baby's care when mother is ready to be discharged from the hospital, care for the baby in the NICU, home palliative or hospice care or community hospice. End of life care needs. Some families may not want to address these issues prior to the baby's death, so it's important that this happens simultaneously after the baby's death. So the location of the death, whether at home or the hospital, families preferred funeral director. If an autopsy or a postmortem biopsy is required, special genetic testing is required. Organ or tissue donation plans if they're appropriate from the family's perspective. The role of children's hospice in perinatal palliative care and advanced care planning. The conclusion of this survey was that children's hospice plays an important role and in the perinatal care of babies and families following the diagnosis and recognition of a life-limiting or a life-threatening condition. It is quite relevant for us because the family-centered approach to care from a broad biophysical perspective means that hospices make an important contribution to the clinical needs and the psychological needs of the families antenatally and in the neonatal period and after that. Memory making is also an important aspect of these consults because this is how they are going to live further with the memory of that child. So this could include photographs and videos, which could serve as a touchstone to the family's moments of interacting with their baby. Plaster molds can be made of the baby's hands and feet using 3D technology. Imprints and other memories can be done so that at the hospital itself, that complimentary hospital birth certificates or a cardstock or on t-shirts or hats or any item of clothing for the parents of sibling can be done. Certain cultures could be opposed to collecting locks of hair, while certain parents might want to collect locks of hair. Scrapbooking can be told to be done during the prenatal period and after the baby's birth. Personalized items such as gowns or hand knit caps or a blanket, small toys or tape recordings of parents' voice singing lullabies to children or babies' rings can be used. Memory boxes can be purchased, and a lot of things that the child has been wrapped around. Clothes, the baby wrappers, the clothes, the toys, the handmade caps can be contained in that. Opportunities to interact with the baby, which includes touching and holding the baby, including kangaroo care, rituals of blessing, naming, and dedication, recognition of life, baptism of the child, bathing and caring for the baby's body while living and after death, rocking, cuddling, and laying down with the baby in the bed, reading books to the baby. All these could be done as a part of memory making and has a deep impact on the families. Coming to sibling grief, these are mostly the forgotten mourners. Children have a lot of emotional burden from unresolved grief that surviving siblings might experience and can be carried into adulthood. And this is insufficiently understood. Siblings and families bereaved as a result of perinatal loss suffer in two ways. That is, they mourn the loss of the expected sibling, and they also mourn the loss of a parent as they knew prior to the loss. Parents can be so overwhelmed with their own grief that they are blind to their children's grief. Of importance here is that parents should also seek professional help so that they don't disregard or give less importance to the other children in the family. Coming to spirituality, this is the search for ultimate meaning, purpose, and transcendence and experience of relationship to self, family, and others in community, society, nature, on the significant or sacred. For some, spirituality could be related to religious beliefs, and for others, it is not. Of importance here is to understand that a lot of mothers or even parents could be in a lot of emotional trauma right now, and they might also ask questions like, why me, why our child, why us? So it's really important for us to address all these issues and give them proper strategies to cope. Cultural and religious aspects. With increasing diagnostic facilities, life-limiting conditions are now diagnosed in the antenatal period, and religious considerations are important while discussing and deciding on the pregnancy management. Faith-based views about termination of pregnancy need to be explored with the family and taken into consideration while offering the management options of managing the pregnancy. Now, when to consider the genetic counseling? If there's a history of multiple congenital malformations, if there's neurological disease without any explained etiology, or with pediatric cancers, we need to understand that there may be the need of genetic counseling for such parents. It aims to promote informed decisions by the involved family members, to clarify the options available, the treatment, and the prognosis, explaining alternatives to reduce the risk of genetic disorders, decreasing the incidence of genetic disorders, and reducing the impact of these disorders. So the potential benefits that we've understood so far regarding early and integrated palliative care referral in the antenatal period is that parental understanding of the fetus or the newborn's disease trajectory and outcomes is improved. Parents hearing about all the possible care options, clinicians understanding the family's narrative and the pertinent value perspectives, including the cultural, spiritual, sibling, and extended family. Clinicians understanding of the parental perspectives on desired information. Are they detail oriented or the more big picture folks? Do they want the minor details about what can be done, or they just want to know if the baby is going to survive or not survive? Clinicians and parents exploring the goals for this pregnancy in view of fetal diagnosis. What are their hopes, but also what are the acceptable outcomes which are going to happen? Clinicians and parents exploring acceptable risks, harms, pain, and procedures within a context of potentially limited benefit. Example, should resuscitation include intubation, ventilation, chest tubes, in a known anhydramnios pulmonary hypoplasia case? Clinicians and parents exploring acceptable use of limited technology in the ICU. Coming to the barriers of palliative care referrals, why these patients are not referred to us. It could also be because of equating palliative care with the care of imminently dying patients. The obstetricians or the pediatricians might have a desire for continuity and not to consult out the dying patient. There's difficulty in timing amid the disease trajectory and not knowing when to consult the palliative care physician. Culture of technological imperative, it precludes simple comfort measures, perception that parents aren't ready yet for a palliative care consult, not wanting to reduce the parental hope, self-confidence in the ability to provide complete care. That is, certain physicians might still have no perceived value of palliative care. Palliative care consultant may offer choices that the primary clinician does not agree with. The consult is a sign that the primary clinician is giving up on the patient, and the clinician does not have adequate neonatal or perinatal expertise. System problems, the time constraint and lack of palliative services at certain centers or in certain countries or certain areas in the country. Patient or family cultural or language or religious obstacles. All these are the barriers which may hinder further care that can be provided and can also change the mode of intervention that parents opt during this sensitive period. So there is an article given by Stephanie Kokora and Nathan Gollahan, the antenatal palliative care consultation, the implications for decision making and perinatal outcomes in a single center experience. So this study says that the incidence of death for live-born infants with poor prognosis was similar with and without those who had antenatal palliative care consults. The non-survivors with antenatal palliative care consults were more likely to have a comfort care plan and a shorter in-hospital death than those without. Most of these diagnoses involved prematurity, IUGR, congenital diaphragmatic hernia, renal or anhydramnios, anomalies which were having identified syndromes with normal growth, no identified syndrome with growth restriction. They have chromosomal abnormalities such as the trisomy 13 and 18, isolated brain abnormality, and certain other diseases. So the results of this study were that the outcome was the same. There was death. There was no change in that. But the resuscitation decision at counseling in those who receive antenatal palliative care, 58% chose to go for comfort care as compared to 16% chose to go for comfort care, despite the outcomes being the same, despite the prognosis still being the same, despite the diagnosis still being of a disease which is life limiting and life threatening. And resuscitation delivery decision at the delivery also, there were certain patients who also chose for a change in their plan. Some wanted to go for comfort care and some wanted to go for a trial of therapy, and some wanted to reduce the interventions which were provided during delivery. Um, Also, the Kaplan-Meier survival curve showed that there were certain patients who were also discharged who went home, and there was one patient who also lived longer, more than 60 days. So what we understand from all this is that certain things that we should think upon is that which fetal diagnosis warrant such antenatal palliative care conversations. Does a consideration of a limited neonatal resuscitation or a comfort care paradigm take away parental hope? Is there any added value in the interdisciplinary discussions, inclusive of neonatology and palliative care, or with a chaplain or a social worker, compared with solely antenatal counseling by a neonatologist? Do parents report any benefit of being engaged in these conversations and decisions upstream, like they do in retrospect when they are engaged in such end of life decisions in the NICU? And how many APCC visits are beneficial? Only one or multiple? Does antenatal palliative care consult reduce the parental decision of regret and leave families wishing they had done more or gave up too soon? So that's the end of my discussion. Thank you.
Thank you, Shruti. Would Dr. Manasi want to put any perspectives?
Thank you.
Shruti. It is a very, very comprehensive talk, and thank you for taking so much of an effort to do this. It's really very clear. Yeah, over to you, Mansi.
Thank you, ma'am. Thank you, Shruti, for the presentation. I think Shruti has covered quite a lot on the topic. Just some practical aspects that can be mentioned are when you're in the antenatal setting, and there are mothers who are coming with repeated such pregnancy losses or even malformations, for example, in their children. There is one element of stigma that needs to be addressed, and Shruti briefly mentioned it, but when you're practically counseling, that needs to be taken into account. Another thing is just cultural and more setting specific counseling when it comes to antenatal care, because some mothers may be in a capacity to go ahead with pregnancies. Some may prefer that you help them with early abortions or going through that decision of facing their family with this situation and involving elders in the family. So just these 1 or 2 points on that. Thank you.
Thank you. I don't see, there's lots of compliments for Shruti, and I know that Mansi and Shruti worked together to make the presentation. So compliments to both, and everybody has done that. Thank you very much. I don't see any questions because I guess the presentation itself was was very comprehensive and easily understood, and what all we need to do is about practical points. Just my question to you, Dr. Manasi, because you are a pediatrician by training. How well do you think this is handled in regular pediatric or, obstetrics community?
Thank you for the question, ma'am. I think from my experience, what I can say is that there is an immense need to understand antenatal palliative care and its existence also. Sometimes when it comes to obstetrician-pediatrician relationship, that's also a struggle in practical settings. So even getting these two experts on board when you are dealing with a child with such a difficult diagnosis is step one. So when we are looking at programs that are educating pediatricians, I think in the antenatal space, we'll have to involve obstetricians also more closely. And as Shruti had mentioned, that it's a multidisciplinary team. So psychological support in these mothers, pregnancy itself, even in a normal pregnancy, I think that need is still coming up. But when it's such a pregnancy, practically there are areas where this lacks. And in the early neonatal period, when some child is in the NICU, I think it is a very hard decision to take the step of now not aggressively looking for resuscitating the child or continuing that medical support. But there is a need for hospitals to come up with such policies where these decisions can be taken. Otherwise, they are pretty prolonged in many settings. Yeah.
I think there is a question about memory making by photography.
Yeah. Yes, so this memory making in particular, I'm glad that you asked this question, Divya. It is very specific to what a parent would like. And this differs across settings. Some parents are very comfortable with talking about death or keeping remembrances. But at the same time, if parents, like you said, for babies with congenital abnormalities, if they are not eager about photos, then maybe just a small handprint, or maybe just the mother's scrapbooking of how she felt throughout the pregnancy. Or sometimes children who are born with congenital abnormalities, yet they have been able to spend some time with the mother. So there are small things like a band over the child's hand, for example, can be kept as memory. So it is nothing by force. It is something that they would prefer if they want to. That's only when you would help them with that.
Yeah, I've seen some with just the, the forehead with the tika on top. So that is just a memory. This. So thank you for answering that question. One thing I really liked is about, the stigma that you brought up, Shruti, about this, and keeping the mothers with the healthy pregnancies separately to these mothers. It's very, very important, because this is just, we are seeing on the surface. In the background, there is really a whole bit about family stigma. Forget the social stigma, the family stigma and the guilt and the added pressure of the future pregnancies and how to manage is just terrible. So I don't see there are any questions. So I think thank you, Shruti, for an excellent presentation and for the hard work, and Manasi for guiding Shruti. Dr. Punita has made her comment about palliative care, antenatal palliative care not being a really routine thing. So that's where our work is cut out. Thank you very much, and over to Sushma ma'am.
Jaita ma'am, I think Dr. Shushma had to leave for another
All
meeting.
right, okay.
Yeah.
Okay, great. So thank you very much then, Archana and everybody in the audience for being with us today. Thanks again to Shruti and Manasi, and we will see again next week. Thank you. Have a good day.
Thank you, ma'am.